Value-based care is hard enough even in a well-resourced setting, so just try making it work in a rural area without the scale, staffing, and population density. But that's the market Tim Gronniger, CEO of Caravan Health, is addressing, bringing together safety net and community health systems to deliver high-quality, low-cost care in a culturally sensitive manner, and with some 340B revenues in to sweeten the pot. From almost good enough to be a professional trombone player, to a graduate degree with a weird name, to the halls of Congress, and now at Caravan, Tim shares his story in this episode of the HealthBiz podcast. I'm your host, David Williams, president of Health Business Group. Enjoy the show. Well, Tim Gronniger, CEO at Caravan Health, welcome to the HealthBiz podcast.
Thank you. I'm thrilled to be here.
We're going to talk a lot today about Caravan and even beyond that because you've had a new acquisition. But I want to start more toward the beginning and ask about your background, your upbringing, any childhood influences that you have brought into your current work.
Yeah, I was born and grew up in the suburbs of Kansas City, in Olathe, Kansas. And my mother was a very strong influence on my life, still is, taught us, everything I know about how to get through in life and in the world. And really all of my family was really strong influences in my life. And I was very lucky in that regard. And they set me up on, seeing the parenting in the Washington, D.C. region now, and just looking at it through the lens of a parent myself and thinking about how parents did it back then. My parents were indifferent to whether I went into to music and followed my passion in classical and jazz music as a trombonist versus going at a school where I was not going to be very competitive or very good because I was a good high school performer, but realistically not on a trajectory to professional music accomplishment, or go to a science career at an Ivy League school, which is what I ended up doing. So my parents had a remarkable ability to focus on, pushing me to do something that I enjoyed rather than honing in on the highest economic, maximizing net expected income over a lifetime, which I think is, behind a lot of parenting calculations today.
Very nice. Well, I didn't play the trombone. I played the trumpet. I had a passing interest in the trombone, but I was too short and maybe still am to be able to, do the full extent of the slide to be able to play the whole scale. So the trumpet worked out well for me, but I always loved the trombone, to tell you the truth.
Yeah, well, you've got more range for error because no one ever knows exactly if you're...
Yeah, it's about right. It's somewhere around there. It's not like to press the wrong valve down and it's too obvious, but that only takes you so far. And I think that's probably the difference between a decent elementary school trombone player versus, I think even by high school, they got it figured out about where it's supposed to be.
That's right.
So, you mentioned your higher education. You have a few degrees, and you have one degree that I wasn't so familiar with, which is MHSA, which is not, at least not MRSA. That would be a bad brand for a degree. But what is it? What is an MHSA?
An MHSA is a Master's in Health Services Administration. It's a sister track to Master's in Public Health at the University of Michigan. A number of health sciences and public health schools have this track for folks who are generally going to be on an administrator's pathway or work, someone might choose between an MHSA and an MBA with a healthcare focus. So it's intended to, it actually has a very set of defined protocols that many people use it later on, where it feeds into a fellowship pathway. You can become, these folks often get the letters after their degree later of a fellow of the ACHE, the College of Health Executives. So it's one of these administrators tracks that was intended to mirror medical credentials tracks, which isn't how I ultimately ended up using it. But I learned a ton about structures of healthcare systems, payment systems and design, and did a whole bunch of research and economic work there as well.
No, it sounds very fruitful. When I read the description, I hadn't heard about it before. So, after school, you went into government service, and it's probably how you got yourself over toward Washington, D.C. But what was the thinking for that, and what was your path within the government?
Yeah, I was on a track in college to do an MD, PhD. Like, I was all in on biochemistry and going to med school. I had worked for years in high school in biochemistry labs at the University of Kansas, and then in undergrad at Harvard, was working at Harvard Med School labs. I was like burned out on bench work by the time I was a junior in college, and I
Yeah.
realized I needed to change something. I had my first career crisis at the age of 20 or whatever that was. And so in the lab, I had been really interested in hearing health policy discussions, and there was significant legislative action then around the Medicare Modernization Act, and in college around the Balanced Budget Act, and before that, attempts at health reform during the Clinton years. And so I had been tracking that loosely, and one organization that kept coming up as being right in the middle of everything was the Congressional Budget Office.
Right.
And I thought it would be just so cool to work there, and I'd be able to learn, be in the middle of all of the legislative action. I'd be able to, figure out how all of these confusing acronyms work, how the government actually works. And so it was sort of following a loosely founded intuition based on what I was hearing on NPR and endless days in the lab.
One of the sometimes underappreciated elements of government service is that at a young age, right out of school, you can have some incredibly senior exposure and make a big impact relative to what you could do at any kind of company. At least what I saw. I grew up in Bethesda. Was that your experience as well?
That's absolutely true, and that is also levied sometimes as a criticism of the current structure of how policy is made, which I think is also fair. But the reality is that the staff on Capitol Hill, both the nonpartisan staff like the Congressional Budget Office and the Medicare Payment Advisory Commission, and then the committee staff, which I later joined, and member staff that support members and that support the process of designing and drafting legislation, they have a wide purview to do research, to call, when I did go to the committee staff, I was probably 30 or so, and I could pick up the phone and call just the head of almost any company, any professor across the country, any think tank, and they'd be willing to give time to help me, acting on behalf of whether it was Henry Waxman or members of the Energy and Commerce Committee, to help them do a better job crafting health policy. So it was a tremendous, thrill and responsibility to be able to be there and to distill all of the desire of members of Congress and of the public to do some big things on health reform, payment reform in my case, and to try to harness hundreds of people across the country and distill their expertise down into concrete ideas and options for members of Congress to consider.
Now, when you decided it was time to leave government and go more to the corporate world, you made sort of a gentle half step by going into my business, which is consulting. So, what was the thinking there? How did you get into that, and what were you doing as a consultant?
Yeah, so I spent a number of years in government, going from CBO to the Hill to the White House and then CMS, and my goal with going to CMS was to get closer to the operations and the business of healthcare as it is practiced by physicians and hospital leaders and clinicians all across the country, and the array of technology partners and others that support them. So my path had always been focused on, I stayed in government longer than I ever intended to, partly because we were right in the middle of these generational shifts that were,
Right.
Just exhilarating to be a part of, and so much work to do inside the government. It never felt like we were done until the end of the Obama administration. So that end of the Obama administration came at a time when, it was abrupt, of course. We expected to be continuing on, or I thought I'd be loose, gently transitioning out at the beginning of a Clinton administration at the time. And so I wasn't actively trying to find my next gig, even though I thought it'd be a year or two. But it all got accelerated with the Trump election. And so January 20th, I logged off, January 2017, I logged off of my CMS accounts for good. And I wanted to take some time and not rush into anything. And so consulting was the path for me to do some gig work. I did some work for the American Medical Association, for instance, in their CPT and Health Services Committee. I did some tour, some speaking work, and it was not like deep long-term projects per se, but they lasted a couple months, and I learned a lot. I did some work with Socially Determined, which is at the time was a startup in the DC area, and is still in the DC area. It's been growing pretty robustly the last few years. So it was a chance to get exposed to a whole bunch of different people doing a whole bunch of different things, which was helpful for my job search as well as help paying the bills during the transition.
So then you made, I would say you leapt on the corporate bandwagon, but if not the bandwagon, at least the Caravan, by going to Caravan Health. And what was that about? And in particular, what was it about Caravan, or what is it about Caravan that kind of attracted you? What's the main emphasis? What need is being addressed there?
Yeah. So I hadn't heard of Caravan in 2017 until a friend called up and said, "Hey Tim, I'm on the board of this company. They've got a really dynamic founder. They're doing great work in the MS and ACOs and in supporting improvement for rural providers, for smaller providers. Let me introduce you. I think this is your next gig." Honestly, he was very direct about it, and I laughed and said, "Okay,
Yeah.
we'll take the call." This was someone who's a good friend and is still a good friend today. And he introduced me to Lynn Barr, who founded Caravan, really firecracker of a personality. She's on the MedPAC advisory board now. And she had founded Caravan as the National Rural ACO in 2014, and it had grown through word of mouth and referral to serve, at the time, about 150, primarily rural health systems all over the country. And their mission, what really drew me in was it was a group of mission-driven capitalists, smart business people who were doing just what we hoped the alignment of new incentives coming out of the government would do, which was to create what Don Berwick likes to call the business case for quality, right? Of now there's these opportunities to have a contract with the government for total cost of care. How do you actually use that to deliver better care, which was really the organizing arc of my career in government of, piecing together better options and better payment solutions from the government side. I wanted to pick it up from the private side to actually implement these changes in the quote unquote real world, working with providers who were answerable to real bosses and real resource constraints. Our clients are not the ivory tower systems where it doesn't really matter if this work succeeds or not. If this work doesn't succeed, then they're likely to fire us, and they're likely to, get asked hard questions in their annual reviews or lose their jobs. And so this was, where the rubber meets the road for me, and it's exactly what I hoped it would be.
It wasn't completely obvious in 2017 about what the time frame would be for value-based care, whether it was really going to move forward or not. How much did it matter what occurred kind of at the top of the federal government from that standpoint to the success of Caravan?
Yeah, it's a good memory and a good point. At the time, Secretary Price was in charge of HHS for a relatively short period of time, and he was very against bundle payments, for instance, and mandatory bundle payments as from the perspective of like a small orthopedist practice. Whereas I didn't sweat that too much because I was familiar with the structural alignment that still undergirds all of this work. And it's easy to get to look on any given day or month or year and say, wow, this is really a slog and I wish that this was faster. But we've got permanent statutory support in the Medicare Shared Savings Program and the Innovation Center. We have alignment across 4 consecutive administrations, bipartisan, that this is the direction that they want Medicare and other payers to go. And we've got really robust alignment from private sector purchasers as well, and increasingly from employers. So if for the most part, I don't sweat that the payment system is going to go against value-based care. I think it's just a question of how deep is it? Do we allow ourselves to get distracted and chase other goals? And some distractions wouldn't even be fair to call them distractions, like the pandemic and the various both health and financial problems that created for providers. So it's going to vary from year to year, but the long-term direction I've been confident for a long time is towards total accountability for costs and quality.
Now, you were recognized as a so-called top 25 innovator by Modern Healthcare. And why did they select you for that? What was any one particular innovation, or what was the focus of that award?
Yeah, I think that it's a recognition of the success of Caravan Health and our clients and our teams. And we've been able to stitch together a solution for community hospitals and rural providers that are able to participate in accountable care and generate real income off of it by investing in primary care in ways that were not available to them if they were working on their own or trying to do it without the support of this platform. And so we created the concept of a collaborative ACO where rural providers and community health systems are working with 100 other systems like them rather than trying to go into these ACO products alone. And we've put together technology solutions to enable them to know what they need to do next with their patients and to keep track and to identify systematically what their biggest opportunities are. So, this was it was great to be recognized along with a really distinguished list of innovators. But I think that it's a reflection of a whole team and a whole company effort.
One of the reasons you can imagine why there's a bipartisan and longstanding support for value-based care is that it's something not just for the cities, but it's for other kind of geographic setups. There's a lot of challenges with rural healthcare. What are the specific issues as it relates to rural providers playing in value-based care? You talked a little bit about the solution that you're providing so that they can not have to go it alone. So there's clearly a scale issue. But what are some of the challenges that would be particular to, let's say, a rural area versus where I am, in a city?
Sure. I'll give you two primary ones. One is staffing is an acute problem in all areas of healthcare, but it's a consistent multi-decade problem in rural healthcare where it's not just patients leaving northern rural areas for the south, but everywhere skilled personnel, clinical, non-clinical, are just hard to come by. And so we constantly have to be creative in what types of solutions that we can bring to help backfill or to help train up new staff that are having to rotate in. And one of the, as an aside, one of the things I'm excited about with Signify is being able to bring in direct care management support and care navigation support that we don't have to ask our clients to provide because we can provide it remotely. That's something that's relatively new in the industry. It's becoming commonplace. And then two, rural healthcare challenges in value-based care is just the complexity of the payment systems. So what we do and build for a physician fee schedule clinic, a fee-for-service clinic in a small urban environment where we are able to put together a very specific workup of pairing an annual wellness visit with an E&M visit. It becomes challenging when you have billing rules for rural clinics that prohibit that type of billing arrangement. And so it's been really important for us to be aware and to design alternatives for rural clients who have who can't bill in the same way and have to design their workflows to accommodate the rules that they have to operate under.
One thing I noticed mentioned in your literature is about the 340B program, and that's usually like the chief source of income for a variety of different programs. But how does 340B fit in with what you would do with your clients?
Yeah. So we didn't focus on 340B issues at all until a couple of years ago. We did a poll of our clients at our symposium and asked them, what are we not doing that you want us to pay more attention to? And by far, the 340B program was at the top of the list. And for those who don't know, the 340B drug discount program allows safety net providers, federally qualified health clinics, a number of rural providers, the ability to access drugs for their patients at Medicaid best price, essentially. You need to meet certain documentation requirements, and it needs to be applied for patients who are eligible and for physicians who are eligible, filled at a pharmacy that's eligible. But if you can cross the various requirements, then it can be a very significant benefit to a system. And can help them defray the costs of operating population health programs or operating, passing through those discounts to their patients. There's a variety of options for how you can deploy that savings. And so as we dug in, we realized that there were a handful of data problems and a handful of documentation problems that were very well addressed by population health workflows of keeping tabs on your patients when they aren't in front of you, patients that are being managed by an external specialist, for instance, and making sure that appropriate follow-up care is happening, that it's then being documented back with the primary care practice or the employed practice. And there's a few pieces and a few tweaks that clients can make to capture significant new revenue that doesn't come out of the population health bucket and doesn't require a ton of expenditures of new staff time that could otherwise be directed towards managing those patients and their high-risk medications.
Thanks for starting off your answer by explaining what 340B is. I realized when I asked the question I had neglected to provide that context, so thank you for that.
Of course.
On Signify, you mentioned your excitement about Signify. Now, Signify Health is now, I think, the parent company
Right.
of Caravan Health. Can you explain how that came together, how Caravan fits in, and what it means for you?
Yeah, absolutely. So Signify, we met through a process where we were evaluating our options for building enhanced solutions in post-acute care, in more robust disease management, outsourced services to support our patients to deal with some of these staffing issues. I knew the legacy business inside Signify, which is Remedy Partners, which was like Caravan, an early value-based care company that was focused not on ACOs, but on the various CMS bundled payment programs, and had moved into commercial episodes as well. When we met Signify, they said, look, you want to build all of these things. We have them built already for our episodes business, or for this other big part of our business, which is in-home evaluations for Medicare Advantage patients. We are going to be in 2 million Medicare Advantage homes this year, identifying needs, filling quality gaps, and documenting it all and feeding it back to the primary care system. We have all of these resources that would be very useful for your clients. Do you want to work together? And so it became a merger conversation very quickly at that point, and we were able to, it's not hard to line up the synergies here, where we can bring those outsourced services, we can bring a really robust post-acute care management capability, we can bring something that no other ACO operators are doing in significant scale right now, of really robust specialty care management program, which is not something that ACOs have done much of historically. And so it all made just too much sense for us. And so we went through that really quickly, and we closed at the very beginning of March. We're about a month in right now.
Great, congratulations. And so you're still running Caravan Health, and you have a senior role within the broader Signify Health organization. Where do you see things going from here, recognizing that it just started off for you?
Yeah, I'm all in. I'm loving the Signify team and the vision of what we're putting together. We have all of these unique resources to bring to bear on population health to serve both the Medicare market and the Medicare Advantage market, but also commercial payers and employers who, you've got a short list of employers who have been trying to be creative in value-based care for a long time. The Boeings and Walmarts of the world. But from what I'm seeing, that list is expanding to much more Main Street companies being willing to get creative here. And so the sky's the limit on what we can do with this combination of people and talent and assets that we've got assembled. And I'm really excited for turning that into, helping our clients take better care of their patients.
Terrific. Now, do you have any time for reading, and do you have anything to recommend to our viewers and listeners, if so?
Yeah, I tend to split pretty evenly between fiction and nonfiction, depending on what's going on, and it's been strained lately. But I did just finish on the fiction side. I just finished Matrix by Lauren Groff. Mm-hmm. I don't know if you've heard of it, but I think it was released last year. A really unusual book about an orphan who grew up in 12th century France and England, was sent to a monastery, and eventually, was put in charge of it, and grew essentially a mini Vatican, and all of the permutations of that, really austere and then complicated life. It was a mind-bending read on certain levels, really interesting. And then, in the nonfiction, I was reading, not quite done with, but deep enough to get the main ideas. A World Without Email by Cal Newport.
Yeah.
And it's provocative and really challenges the way that hive mind corporations work, and I will say that the way the government works too. And I think with remote work and with remote teams and with a much more fluid working environment, I think it's important for managers to be thinking creatively about what we can do to both work better as an organization, but also take stress off of individuals so that they don't feel like they can't actually think and work, and because they're responding to emails and Slacks all day. So not ready to say that I'm advocating for an organization without email. I don't think that that's practical, but I'm intrigued by ideas about how to get creative on some of these problems.
Those sound like two good recommendations. When you first were describing the Matrix, I wasn't sure if that was a fiction or nonfiction, depending on which direction you were going. So but when you contrasted it with the nonfiction one, then I knew it wasn't for real.
Yeah. Apparently, it was based on a couple of historical characters that very little is known about.
Yeah,
but I trust that this was not actually what happened in their lives to a first order degree.
Well, great. Well, Tim Gronniger, CEO at Caravan Health, now part of Signify Health. Thanks for joining me today on the HealthBiz podcast.
Thanks, David. I enjoyed it. Have a great one.
You've been listening to the HealthBiz podcast with me, David Williams, president of Health Business Group. I conduct in-depth interviews with leaders in healthcare business and policy. If you like what you hear, go ahead and subscribe on your favorite service. While you're at it, go ahead and subscribe on your second and third favorite services as well. There's more good stuff to come, and you won't want to miss an episode. If your organization is seeking strategy consulting services in healthcare, check out our website, healthbusinessgroup.com.